try to tailor the lecture in light of our current pandemic. So we're going to try to keep this pertinent to our clinical practice during the times of limited PPE, social distancing, and multiple other factors that have affected our care during this pandemic. So before I get started, I just want to give you guys a warning since you're at home. Anybody with dogs, cats, or children who are sensitive to images of eyeballs, you may want to either remove them from the location or just not let them see the screen. I think even for some of us, some of these images are just a little nausea-inducing. So just want to keep that in mind for anybody with family members that are present. All right. The objectives, we're just going to kind of keep in mind what I want to talk about. We're going to interpret some data in regards to how COVID-19 can present with any type of eye symptoms. There's a lot of upcoming research. Studies have come out on how clinical presentations of COVID-19 have presented. And so we're just going to discuss how they may come in with an ocular complaint. We're going to learn how the pandemic has changed clinical practice, not just for us, but for ophthalmology, and how that actually affects our clinical practice as well. We're going to discuss tools and methods we want to reduce exposure from our patients, especially now with limited PPE, trying to get into the room and just have everything you need during your initial assessment so you're not going in and out and bringing multiple things in and out with you. So just be prepared for what you want to bring with you into the room to reduce exposure and reduce use of PPE. And finally, I just want to review the absolute ocular emergencies so that you know exactly what you need to rule out. And if you have encountered these conditions, how you're going to make the diagnosis so that you can appropriately get them treated. We're not going to get into all the details of all the signs, symptoms, and everything that go along with all the conditions. I just want to focus on which ones you should be thinking about and how you're going to manage them. So first, we're going to talk about how COVID-19 can present in regards to any type of ocular emergencies. There's not too much data. As you know, this is fairly recent in the past several months. However, there is a few case reports and a couple of analyses that indicate how they may affect the eye. So to start with, this is the first case report from, this one came from China. And what they essentially looked at was a single patient who had diagnosed COVID-19 who on day 13 developed conjunctivitis. You can see here the images, the right eye and the left eye, all on the left are day 13. The images in the middle are day 17, and the images all the way on the right are day 19 after they were treated with eye drops, the ribavirin eye drops. And so you can see here, this essentially looks like any standard viral conjunctivitis. Again, this is only a single case report, so definitely not something that was very common, but just so you guys can recognize, conjunctivitis can potentially be a presentation of COVID-19. Further studies looking into this, the Journal of Medical Virology, there was a study of 30 patients that were hospitalized for COVID-19, and only one had conjunctivitis. And only that patient, and not any of the other 29, had evidence of the SARS-CoV RNA in their ocular secretions. Now, that's just to say that they found RNA. It doesn't necessarily mean they found infectious viral particles. They just found portions of the RNA in the PCR. So only the one patient that actually had a presentation of conjunctivitis had evidence of RNA in their secretions. None of the other 29 who did not have conjunctivitis were found to have RNA in their ocular secretions. So from this, you can suggest that if they do present with conjunctivitis, it's possible that there is RNA in their secretions, but not necessarily. So another study, this was essentially a retrospective study looking at the clinical signs that were documented on the chart for patients that were hospitalized for COVID-19. Across 30 hospitals in China. So they looked at what were their physical exams, what were their symptoms. They looked through the chart. So that's only 0.8%. So that's a really, really small number. They did not actually test any of these patients for whether they had RNA. This was just looking retrospectively at the charts of patients that were documented to have COVID-19. So again, not a very common presentation, not very suggestive of having the infection. And one more final retrospective case series looked at 12 of 38 confirmed COVID-19 patients. So 12 out of 38, so less than half, had any type of ocular abnormality described as either chemosis or secretions, and only 2 of those patients had a positive conjunctival swab for the RNA. Now, these were really critically ill patients who may have had chemosis or conjunctival abnormalities due to being on the vent, hospitalized, getting fluids, lots of other factors that can be associated with having an abnormal ocular exam, even just from having dry eyes. And so, again, not very classically consistent with the diagnosis for COVID-19. So essentially, one more study. So 72 patients with COVID-19, 2 had conjunctivitis, and only 1 of the 2, and none of the other 70, so they did actually test the tears of all the patients, and only 1 of the 2 that actually appeared to have conjunctivitis had RNA in their tears. So summary from this, at this point, very few patients develop viral conjunctivitis. Again, remember, like less than 1%. It is not a common presentation of COVID-19, so I wouldn't necessarily assume that a patient presenting with conjunctivitis has this condition. I would definitely consider other presenting signs, symptoms, risk factors. And obviously, because we suspect in the emergency department that every patient has coronavirus, that I would still have caution when examining these patients, especially since a lot of our ocular exam includes getting less than 6 feet from the patient. So, all right. So that leads into the next topic of how does this change our clinical practice? Well, first, let's determine how it's affecting the clinical practice of our ophtho colleagues. The American Academy of Ophthalmology on March 18th made a statement that due to the COVID-19 pandemic, the American Academy of Ophthalmology now finds it essential that all ophthalmologists cease providing any treatment other than urgent or emergent care immediately. Obviously, this has a huge impact on our patient population as well as our clinical practice, as now these patients are no longer able to get their ocular examinations performed, and they may be turning to the emergency department for those reasons. Now, this statement has said that they can cease providing treatment other than urgent or emergent care. So let's discuss overall the reason for that. They want to reduce the spread of infections, so just like everything is closing down, to keep patients at home and not to be exposing them to each other in the waiting room, to the physicians that are examining them. Also, we need to preserve PPE, as obvious and as I suggested previously. In order to do ocular examinations on your patients, you need to get very close, and the ophthalmology clinics and et cetera don't have all the PPE. They need to preserve it for the emergency staff. So medical supplies, resources, we all understand these are the reasons. So what they are doing is encouraging telemedicine. And so they're requesting that the ophthalmologists actually triage their patients through telemedicine to determine if sometimes they can even make a diagnosis over telemedicine, just as we can from across the room. Sometimes we can just look at a patient and know exactly what they have, but also to determine when they can get seen if it does appear to be considered an urgent or emergent situation. However, a lot of the algorithms that they have put out there for the ophthalmologists to use for their telemedicine triage suggest essentially, if it's something that you think is either urgent or emergent, just send them to the emergency department. So it becomes our responsibility to evaluate these patients. And they also suggest for those who are seeing patients in their clinic that they do what's called a rapid treat and release, which is something that we can also incorporate into our practice, which I think is what we already have been doing up until now anyway. So again, let's define urgent and emergency procedures so that you know when you're calling your ophtho colleagues what is it that they're actually capable of doing. Again, these are mostly the conditions that we're concerned about, but they can perform. If you actually, if you want, I can actually show you the website directly. There's a pretty extensive list if you want, you're welcome to look through it, but a lot of these are not necessarily emergent, but some of these are actually procedures that they do for pediatrics, so neonatal screenings and things that can prevent progression of ocular problems for pediatrics and neonates. So anyway, I did try to summarize the list for you. How do I go back to my lecture?
Just go back to keynote and start it.
Thank you. Sorry. Okay. So, essentially for our purposes, temporal artery biopsy, canthotomy and canthelysis, which hopefully we'll be doing, but the ophthalmologist will need to perform the procedure after we do anyway. If there's an orbital abscess, enucleation, if there's a globe rupture, they can do laser for retinal detachment. Again, I talked about there's an extensive list of pediatric indications, and of course ocular trauma. And there's so many things that go along with ocular trauma that I didn't want to suggest all of them individually, but just so you know, those are reasons that you can still call your ophthalmologist to perform these procedures. Okay. So what does rapid treat and release mean? It basically means, just do the exam that's focused on the symptoms. You don't have to examine every aspect of the eye, which I know sometimes we do if we're not really sure what we're looking for. So just have an idea of what the patient is complaining of and just do a focused assessment of that complaint, which again is what we typically do in the emergency department anyway. But just for the, just to clarify, some conditions may not even require a slit lamp, fantastic, so just do what you need to do to make a diagnosis. Now I don't think we dilate any of our patients anyway, but for the ophthalmologist, don't dilate all the patients, just focus on their complaints. Use the Pen with a disposable cap, which I believe we all do anyway. And then save your retinal exams only for the patients who really need it. So if you can't find something to explain their symptoms with your anterior assessment, then you can consider doing your retinal exam. And I actually talked to several of my ophtho colleagues, and they suggest that for better or for worse, the retinal exams that we provide when we consult them are not all that useful, and they tend to just go ahead and repeat it on their own, or just consider it as if it wasn't even part of their assessment and ask you to do alternative exam findings. So when we talk about external ocular symptoms, the patients present with like itching, burning, foreign body sensation, dryness, tearing. Again, we're going to see patients that we're not able to see their local eye clinic because they're closed. So you might be seeing some of these conditions. Maybe not. It depends on how people feel comfortable with social distancing. I know I've seen a few that have been referred to the ED by their primary care doctor for their ocular assessment because they had dry eye or they had crusting and they thought it was conjunctivitis. So again, these are your external ocular symptoms, and really the only tools you need going into the room, and just be prepared when you go in to see your patients. Have everything ready so you know what you're going to need. So you don't have to go back and forth. So you're going to bring your fluorescent with you, and you can bring the slit lamp, have it ready. You may or may not need it. If you can make a diagnosis without it, then you don't need to proceed further. So just be prepared. Again, at this point, we recommend using the disposable fluorescent strips, just so that you don't have to take a bottle in and out the room with you, or potentially reuse the same bottle and contaminate it. So fluorescent strips, and then your slit lamp. The American Academy of Ophthalmology has issued a statement that if you do use a slit lamp, they suggest you use a shield. And they're actually providing shields for free. You just have to order one. And there's a website if anybody needs that. But you can see here the image of the shield. It's like a sneeze guard. And so that's to protect you as well as the patient. Okay, so when you do your external ocular exam, a lot of times you can make a diagnosis just by your clinical assessment. If they have a laceration, if it's a sty, if it's conjunctivitis. But the things that you need to think about that you at least need to rule out either by history or by your exam. And I put on here conjunctivitis only if it's associated with COVID-19, which I already described as very, 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 very rare. But if they have other signs or symptoms concerning for COVID-19, you may want to consider swabbing these patients so that they can quarantine and follow up. You want to rule out herpes. And as we talked about the conjunctivitis, so any viral conjunctivitis, honestly, if you do see that, only consider COVID-19 if they have alternative symptoms. Again, when you use your fluorescent, you may or may not need your slit lamp if you have a cobalt blue light. You can see the classic findings of herpes, which are these dendritic ulcers. Herpes infections tend to be more recurrent, repeat, so the patients will say, I always get conjunctivitis, it keeps happening. That's more suggestive of herpes. And so again, you can see that with your fluorescein. Zoster is going to be pretty obvious because they may have the actual zoster rash on their face, and so you want to just consider whether they also have ocular involvement. It may not be visible on the exam, so those are the patients that should follow up with ophtho for a detailed eye exam. Iritis, so that's that hairy limbic flush. You can see it almost looks like conjunctivitis, but it's just around the cornea, and so it's a little atypical in the distribution. And these are typically from the emergency department post-traumatic. Otherwise, it's associated with some sort of auto-inflammatory condition. So if a patient is known to have rheumatoid arthritis or inflammatory bowel diseases, this is something that can classically affiliate with those syndromes, then you may want to be suspicious of iritis. Again, keratitis and ocular ulcers, so corneal ulcers, you can make this diagnosis using your fluorescein and using your slit lamp. You can see for keratitis these little punctate lesions across the cornea. Ulcers, again, are obvious, and we'll talk about that shortly, separately. Cellulitis, again, you look at the patient, it's pretty obvious. If you have a high clinical concern for orbital cellulitis, which I would if I saw this particular patient on this image here, you would need to get a CT scan to make your diagnosis. And so these, again, this list are things that you need to be either rule them out, or if you do diagnose them, you need to get ophtho involved for follow-up purposes and treatment. And then deeper processes. And what I'm going to just say here is if you see a hypopyon, which is this layer, it almost looks like a hyphema, but it's inflammatory cells layering in the anterior chamber, you need to talk to ophtho. All right, this is essentially endophthalmitis until proven otherwise, and so this would be considered an emergent condition. So these are the things you want to rule out. So you want to document, that there were either no evidence of fluorescein uptake, so you've already kind of ruled out your herpes simplex, your keratitis, and your ulcers. There was no associated rash or anything to suggest zoster. They didn't have hairy limbic flush if you're talking about conjunctival irritation. And there was no, external erythema or edema of the lids if you're worried about cellulitis. So these are things you just need to document appropriately, and when you assess the patient, just make sure you don't see anything. All right, so let's talk about true ocular emergencies, and I'm going to try to organize these based off of the symptoms. So we have new onset flashes and floaters. We have vision loss, whether it's painless or painful, and then ocular trauma. And I'm not going to spend too much time on ocular trauma because I think we're pretty good at that, and I think it's pretty obvious when you need to get ophtho involved there. So with your new onset flashes and floaters, and I'm actually seeing several patients with these symptoms in the past few weeks. What do you want to bring with you into the room? What do you need? What do you need to be thinking about? And what do you want to rule out? So your tools, essentially, you're going to use your ultrasound and or maybe your slit lamp. And what are the conditions that you're looking for? Retinal detachment. So I know we've pounded this into you. New onset flashes and floaters is retinal detachment until proven otherwise. So, there is the classic, dunes on a beach when you do your fundoscopic exam. I really don't like doing a fundoscopic exam, especially with coronavirus. You have to get really close to the patient, and we're not really good at it. I hate to say it, it's not very reliable unless you have the tools to do a full ophthalmoscopy. It's not really all that helpful at the bedside for the emergency provider with the tools that we have. But I do love using ultrasound. And I wanted to ask you, this is where my first question comes in, Dr. Bond. If anybody can tell me how sensitive they believe ultrasound is for detecting retinal detachment.
Please go to polev.com/UMEM and answer.
I don't have it in front of me, so I'm going to have to rely on you to tell me.
82% are saying 90 to 100% sensitive.
Fantastic. That's high.
Now it's down to 70%.
High.
20% say 60 to 75, 7% are saying 40 to 50%.
All right. Is everybody done?
Give me a second. We got about 50 responses, so that's good.
Okay, all right. So what was the majority of the answers?
90 to 100%.
Fantastic. Yes, that is correct. It is extremely sensitive, and studies have shown and have validated that emergency providers are fantastic at detecting retinal detachment with your ocular ultrasound. And it is. It's anywhere from about 93 to 100% sensitive, as well as specific. So I think we're very good. If you have the skills and if you've been trained in using your ocular ultrasound, it is a fantastic tool. I know Dr. Flecken, I don't know if you guys have seen his tweets. He's like a comedian, ophthalmologist, that he's been posting a lot of things in light of the changes with the pandemic. I thought this was kind of funny. So even he recognizes that ocular ultrasound is useful, or ultrasound in general. So this is a photo of demonstrating, how we do ocular ultrasound. And I like this because it doesn't bring your face close to the patient's face, and it's actually much more sensitive than doing our own fundoscopic exam. So you use your linear probe, and don't forget to cover the patient's eye with a tegaderm. Let them know that this is going to feel funny. I don't know if you guys are practicing doing this on each other, but it does feel really uncomfortable. So try not to put too much pressure when you actually perform this. This is a normal ultrasound, and I just tried to identify the landmarks for you. When you do ocular ultrasound, you're going to see essentially the cornea and the pupil, the little hole opening there, which is actually nice if you can see that. The iris, the lens, and then essentially the inner part of the globe, and then the retina all the way in the back, and the optic nerve. So essentially, this is normal. So the globe is just like a hypoechoic structure. And then here you can see on the left is a normal ocular ultrasound, and on the right is what retinal detachment would look like. And this is actually a fairly extensive detachment. This patient probably had absolutely no vision, but it almost looks like flapping layer of tissue that is kind of like moving. And what you can do to really visualize it, if you're not sure if you're looking at artifacts, you can have the patient try to move their eyes left and right, and you can see these flaps here kind of moving around as well. They kind of float around. And so that's the retinal detachment. It may not be that impressive. It may be a little bit less visible, like this one here. It almost looks like there's a lens on the back of the eye here, but that's that retinal layer detaching. And then there's a little bit of like some foggy material. Where my mouse is. Here it is. Try to point to it for you. There's some foggy material. That's actually the vitreal hemorrhage that tends to occur with a retinal detachment. And you can also see that material kind of floating around and the patient moves their eyes left and right. That actually can make it difficult to do your fundoscopic exam. If there's a vitreal hemorrhage there, you're not going to be able to see the retina, and so the ultrasound is actually really useful for visualizing. So if you see what to you looks like a retinal detachment, it is fairly specific and sensitive that you can actually confidently make this diagnosis and talk to opto, and they will actually trust that as much more than they would if you said, I did a fundoscopic exam and I think I saw a retinal detachment. All right, so the other thing you want to think about, so you've done your ultrasound, it's normal. So the patient is presenting with new onset flashes and floaters. What's the other diagnosis you need to be concerned about? And in this particular case, it's going to be posterior uveitis. Uveitis is just inflammation of the inner portion of the eye. It's separated into anterior, intermediate, posterior, and then there's even this condition called tan uveitis where everything is inflamed. Our anterior uveitis is also termed iritis, so that means the iritis, that's what we talked about already. Again, same things that are going to cause iritis are also going to cause posterior uveitis, which can lead to onset of flashes and floaters. And so think about it in patients that have risk factors, if they have lupus, if they have sarcoidosis, if they have inflammatory bowel disease, those are the patients that are going to be at risk for developing posterior uveitis. It's a really difficult diagnosis to make in the emergency department. So all I want you to do is for a patient that comes in with onset flashes and floaters, rule out retinal detachment, and otherwise talk to opto and say, hey, I'm worried about posterior uveitis. You need to see them within the next couple of days for a dilated exam. and that's it. That's what you need to do. You're not going to make the diagnosis definitively in the emergency department. So you just need to have a high index of suspicion. All right, next triage complaint is acute vision loss. We've seen several of these as well. So what tools do you need going into the room? If I am going to see a patient that is complaining of vision loss, these are the things I want to have with me. I want to make sure I have some sort of a light. So I want to do my pupillary exam. So make sure you have something. You know, ones at the bedside don't always work. Make sure you have something with you, especially since we're trying to reduce bringing things into the room. Make sure you have a pen light that works. You may want to have your toner pen with you. You want to have your fluorescent, and you may or may not want to have your ultrasound, as again, retinal detachment can present with vision loss. So we're going to kind of work our way from the external exam in. So if you have a patient that presents with vision loss in one eye, you walk into the room and you see a corneal ulcer, I think it's safe to say that you can stop with any additional testing. You're going to use your fluorescent to identify the scope of the ulcer, although most of the time they are visible with your external exam. The fluorescent is necessary to determine the full extent of the ulcer. Sometimes they're a lot bigger than they seem. And so this is an absolute emergency. These patients will need to follow up with ophtho. You're going to want to consult ophtho before these patients go home so that they can get appropriate follow-up, because they need 4 to 5 antibiotic eye drops, and they're going to need close follow-up with ophtho. So these patients are going to need to make sure you make the diagnosis appropriately. All right, the next step. So you've done your fluorescent, it's normal. There's nothing externally on the cornea that you can see that's explaining the vision loss. But, you know, the eye looks obviously different from the others. I think the next thing you want to consider is acute angle closure glaucoma. So you at least need to rule it out. You can bring your toner pen with you so you can measure intraocular pressures. Again, remember to use the disposable cap. And a pressure over 40 millimeters of mercury is highly suggestive, or is essentially diagnostic. Some patients have like a chronic glaucoma. They may have pressures anywhere. Normal is anywhere from 10 to 25. So some patients may have 25 or 30. I wouldn't call that acute angle closure. It's got to be markedly elevated and asymmetric from the other eye. So you always want to measure both eyes, especially if patients have underlying glaucoma, so that you can see this difference. And again, you're going to notice these patients. They're going to have, as you can see from this image here, it's a mid-dilated pupil. The left eye is reacting, the right eye is not. It's going to have the erythema. It's going to look like conjunctivitis. It's very painful. Again, you guys know how to make the diagnosis, and from there you know how to make the treatment. So we're just going to move on. You're going to have your toner pen handy so that you can see that. Next step. So you want to use your pen light to determine whether the patient has a relative afferent pupillary defect. And I think I have a video here. You guys can see what this looks like.
In this patient, you will see that the right pupil consistently dilates as the light is swung toward it. This dilation is called a relative afferent pupillary defect.
You can see that right eye repeatedly dilates with the light, and the left eye will constrict with the light.
This test is the most sensitive and the only objective way
so you can see there, going back and forth, just a swinging flashlight, that there's a problem with that right eye detecting light. So that tends to suggest that there's a problem with the retina or the optic nerve. So, if your patient has a relative afferent pupillary defect, then you need to look at retinal or optic nerve disease. Okay. Sorry. All right, so these are the things you need to worry about when you see that. If you do see that, you need to find something. There is something wrong that needs further workup, needs diagnosis. These are the 4 conditions that are going to be most likely, most common, that need to be looked into. And if you are still stumped after your assessment, you need to talk to ophtho to figure out what other testing is needed. But that is not a normal finding that needs further workup. So if you do see that they have an RAPD, you're then going to look for a retinal detachment. So this tends to be painless, although they can have some discomfort, especially if it's post-traumatic. You're going to have your ultrasound handy. You're going to rule that out because you're very good at it, right? Like almost 100% sensitive. So if you make the diagnosis, you know what to do, you're gonna call ophtho, they need to see the retinal specialist. All right, if that's normal, the next consideration is retinal artery occlusion. These are gonna be painless, unilateral, loss of vision. They may have risk factors, you know, some sort of embolic lesion, maybe they have AFib or hyperlipidemia. These are gonna be hard for us to officially diagnose, especially with our fundoscopic exam, you need to call ophtho. And they need to assess the patient. So these are one of the indications that they would come see the patient. Temporal arteritis, oftentimes is painful, not necessarily. So if you're worried about temporal arteritis in the right patient, older, you know, the age greater than 50, you can order your ESR-CRP to kind of consider the diagnosis as you proceed, you know, temporal artery tenderness. As you recall from that list of procedures that are still being done, a temporal artery biopsy is an emergent procedure that can be done. They don't have to necessarily be hospitalized to have this done. So that's a little bit of a change in our practice. I don't know. I know at Mercy, if we're worried about temporal arteritis, the patient has discomfort, we admit them for IV steroids, we get the ESR-CRP, and then they get the biopsy done the next day. That may change. They may suggest, okay, send them home with oral steroids, and we're going to schedule the biopsy for tomorrow. They're going to come back. So talk to your consultant so that you know how you're going to manage these patients. So if you're considering temporal arteritis, you can get your ESR and CRP. And the next condition is optic neuritis. These are classically painful. They're going to have pain with movement of the eye. And for this particular condition, you're going to get an MRI of the brain in orbits. They can see inflammation of the optic nerve to make the diagnosis. So hopefully this kind of helps you. In the order of events, you know, you go to see these patients, get your ultrasound, rule out retinal detachment. You can send your ESR and CRP and wait for that if you want to call ophtho to make your decision after that. If you're not sure, is this retinal artery occlusion, is it temporal arteritis? And then optic neuritis, again, is classically going to be painful. Some of these are difficult to tease out based on this presentation, but these are the things you can do to help narrow down the diagnosis. So, bilateral vision changes is a different, whole different section. However, the nice thing about this is you're looking at the list, things that cause bilateral loss of vision. So stroke, okay, so their visual cortex is cut out. And they may have other signs suggesting stroke, and they lose weakness or other symptoms, migraine. So these patients can have like bilateral flashes and floaters, headache. They may have had a history of ocular migraine. It's more or less a diagnosis of exclusion, but something to consider. Vertebral basilar insufficiency, compressive mass lesions, and or metabolic or toxic syndromes. And that's something to think about, especially now with, you know, poor access to things. People might be ingesting methanol, and that's something to think about. So again, your stroke, your vertebral basilar insufficiency, you're going to get your CPI, your compressive mass lesions, you're going to put them through the donut of truth to make the diagnosis. Essentially, that's going to be your next step. And finally, ocular trauma. Again, this is pretty obvious based on the history or mechanism or where you're working, that you're already going to know going into the room what you're going to be expecting to look for. But the things that are going to be most emergent are going to be your foreign body, whether they have a corneal foreign body or an intraocular foreign body, retrobulbar hematoma, specifically leading to orbital compartment syndrome. Eyelid lacerations, we've actually had several of these because they're not able to just go to their eye clinic to have their eyelid lacerations repaired. They're coming to the emergency department for these, and you need to know when you actually do need to have optos repair their lacerations. Globe ruptures and chemical injury, which we may be more likely to see, especially now that everybody's using chemicals constantly to clean everything. You know, they may get a chemical conjunctivitis. So your corneal foreign bodies, these can actually be treated in the emergency department and sent home. You remove the foreign body. I know I showed you guys the videos previously. So you're going to do the procedure, and then you're going to talk to opto and say, hey, they need to follow up within 24 hours for a repeat eye exam. If you're concerned about a penetrating foreign body, you can obtain a CT scan to look for the foreign body. So again, think about your mechanism. These are the things that you're going to need to make the diagnosis. Retrovulvar hematoma is going to be pretty impressive. Clinically, there's going to be a sign of injury. At the very least, they may have, an orbital fracture. You're going to make the diagnosis of a hematoma with a CT scan. However, if the patient has loss of vision or clinical signs of compartment syndrome, that is not a diagnosis that is made with imaging. That is a diagnosis that is made with your clinical exam. And you're going to use your tonopen to measure the pressure. It's going to be markedly elevated, just as it is with acute ankle closure, greater than 40. And that's when you're going to perform your lateral canthotomy. Eyelid lacerations, so which ones are going to be amenable to having referred to ophtho? If it's a laceration of the lacrimal canaliculi, essentially, if anything that connects that lacrimal sac or lacrimal duct, so anywhere in like the medial portion of the eye, you can see here this image. So the lacrimal canaliculi, you don't want to just close those shut because they'll scar over and then they won't be able to drain their tears properly. The levator, so the muscle of the upper eyelid, if it damages the levator, they need to be treated by ophtho. It's pretty obvious facial haptosis. They will not be able to touch their eyelid. So you can see here, this one's pretty obvious. If there's involvement of the orbital septum, so if you actually see like fat protruding through your laceration, that's suggesting that the septum has been violated and that needs to be sutured by ophtho. If the canthal tendons are involved, so I intentionally cut the canthal tendons when we do lateral canthotomy. However, if a patient presents, like we had a patient who got bit in the face by her dog, and so the bite actually went through her canthal tendon, and you'll see, because it'll cause like a droopy disfigurement of the eye or the eyelids, the way they come together. Those need to be properly repaired so that they maintain appropriate function of their eyelids. And then the lid margin, for the same reason, if you don't get that lid margin sutured exactly properly, the eyelashes can evert, and they can have a defect that can cause corneal abrasions, and so you really want to make sure these are referred to ophtho. So globe rupture, again, when to consider globe rupture, ocular trauma with vision loss. If you see, for example, this image here, they're going to have what's called like a bullous subconjunctival hemorrhage. So it's basically the entire conjunctiva is inflamed and hemotic and erythematous. If you see this, this is highly suggestive of a globe rupture. You can perform a CT scan. Remember, we don't want to measure pressures when we actually think there's a globe rupture, but if you do measure a pressure and it's less than 5, suggesting a globe rupture. So you can get a CT scan. I want to ask you guys, how sensitive do you think CT scan is for detecting globe rupture?
So please go to pollev.com/UMEM. The question's active. Twelve people so far.
All right.
20.
So how sensitive is CT scan for diagnosing globe rupture?
The majority going with 60 to 75%.
All right. Good job. Yeah. So it's not as sensitive as definitely not as sensitive as our ultrasound, right? So that's something you guys need to think about. If you do get a CT scan, it's only at best 75% sensitive for globe rupture. So if you have a high index of suspicion, you actually, gold standard is operative assessment. So ophtho does need to come and see these patients. So don't rely on your CT scan. If it doesn't make the diagnosis, you still have to have a high index of suspicion. So, chemical injury, I'm going to end with this. The goal of irrigation is to a normal pH. A normal pH is anywhere between like 7 to 7.3. So you're going to irrigate. Hopefully patients will have irrigated before they arrive. It doesn't matter if you have a sink in front of you, you just want to stick their head in the sink, whatever you can do the fastest. But have them irrigate. You can use a Morgan lens, but again, this takes time. You have to go find it. You have to set it up. By that time, they've already had damage. So at the very least, if you have one of those fancy eye irrigation, things have to start there while you get everything else set up. The goal is essentially irrigation. This is an appropriate reason to call ophtho. So again, this would be necessary to get your ophtho colleagues involved. You're going to keep irrigating. until you get that pH that is normal. This is another, this is pretty funny. So in kind of going along in this direction, when you do get chemical sprayed in the eye and you're not sure what their pH values are, this is, I think for now, the things I'm going to mostly focus on are those cleansing solutions, like the cavi wipes, bleaches, you know, any major like cleansing product is going to be basic. And that's actually more harmful than acidic substances. Basic items can actually proceed with liquefactive necrosis, and that's going to penetrate continuously through the structures of the eye, even beyond the exposure that's irradiated out. And so these patients you have to be really concerned about. That is essentially what the things I want you to think about. So those are your most emergent conditions, when to call ophtho. Again, utilize your tools. Try to have everything with you when you go into the room to see patients. Again, I think we're assuming that everybody now has coronavirus, and so to limit your exposure, just try to have in mind whether you need your fluorescein, your split lamp, your pen, your pen light, and then whether you just want to go ahead and order the CT scan to make your diagnosis. So, very end, you can go home. I think I'm ending just a little bit early, so hopefully if you guys have any questions.
Well, let's hear some, any questions, comments? If you have, please unmute. Okay, I'm not seeing anybody unmuting or typing, so can I have a first year, give me some take-home points? Prefer volunteers, but happy to call.
I'll go ahead, it's Bobby. I think one of the things that I got was do not routinely dilate all patients, especially if complaints are anterior or external. And then I also had another one about with hypopyon, if you do see it, you should consider it as endophthalmitis until proven otherwise, and you have to call ophtho for that.
Absolutely, and just to tag on with that, if you see a patient that recently did have any type of ocular surgery, so they are still doing some of these procedures. So if you do have a patient that's coming in because they had a complication and they've had surgery within the past several weeks, I would have a high index of suspicion to assess them for endophthalmitis. Post-op is an emergency, and it's essentially endophthalmitis until proven otherwise. And so those are patients you're going to want to talk to the ophthalmologist who did their surgery.
How about a second year? Brianna, you got some pearls for us? If Brianna doesn't want to answer, let's see who else we have. Tom's talked already today. Jess, do you have any pearls for us? So no PGY2 is going to give me pearls.
Well, I heard my name, so I can speak up. I think one of the things that I got is we're pretty good at using ultrasound in terms of diagnosing retinal detachment, so that's something to be aware of. I know because you have Dr. Glaucoma Fenn's tweet up on the screen, we should not be using the ultrasound to diagnose globe ruptures. And then I was kind of surprised to hear that the sensitivity of CT scan for globe rupture was actually as low as it was. I thought it was a little bit higher.
Jess, I see you found your unmute. Do you have any other pearls?
I thought that the tip for temporal arteritis, just starting the steroids, if you can't get a hold of ophtho, is pretty valuable.
Yeah, and that's going to be your just basically your 60 milligrams of prednisone. I know oftentimes we'll admit and we'll start like 125 with volumetrol. Honestly, studies are equivocal. You can go with either dose. So don't hesitate. You can just start with the PO dose, especially in this day and age. A lot of patients don't want to be hospitalized. They want to go home. If you can set them up to have a biopsy done, that's actually very appropriate. So just keep that in mind. It might change how we actually manage our patients.
All right, any last pearls from third year?
Sure. It's Will. I think one of the really important points or take-homes that I will take from this is the basically when to repair it yourself, when to talk to opto about repairing it. Lacerations in and around the eye, whether they can't open their eye, whether you see fat protruding through the tissue, canthal, tendon stuff. I think that's really important. And a lot of times in the ED, we'll look at a laceration and be like, oh, I think I can just take care of that. But when you have findings like you mentioned, know what your resources are. Use them for backup.
And how do you get eye drops in your eye when you're in space?
You have to basically force them into your eye. It's like a water gun that shoots them into your eye.
Okay, I saw Lauren and Eric had come on too. Do you guys have any additional pearls?
No, that was going to be my and Will stole it.
And just to tag on to that, when you do assess someone with a periorbital laceration, try to have them like close their eyes, and just like you do with finger lacerations, you try to assess it through its functionality. Try to have them close their eyes and move their eyes up and down and left and right, just to see if anything protrudes through the laceration that you weren't expecting to see.
That's great advice. I wouldn't have thought about that. With it.
Especially with the, if they have any defects in function, the laceration may have gone deeper than you expected.
Brianna was wondering, do you know if we have the cover shield for our slit lamp?
I don't know for sure that you guys have it in your department. Even if you don't have one, you can take those face shields that you guys are using, those plexiglass, and you can just tape it right under the part of the slit lamp where your visual, where the eye goggles are. So you can just tape something there. It's just like a sneeze guard essentially, so you're not breathing on the patient and they're not going to sneeze on you.
All right, well, thank you. I don't see any more questions. Let's all take a 10-minute break. We'll start back up at 11:42 for our reading curriculum with Dr. Jane doing the pre-sessing. If everybody wants to turn on their videos, feel free to. Feel free to unmute. And then I will plan to do another town hall at 12:30, depending on what questions you may or may not have.
Says it wants to record this computer screen. Do you want me to deny that? You recorded it elsewhere.
I already recorded it.
Okay. Thank you for your help this morning.
You're welcome.